I want to welcome you all. My name is Ron Dushkin. I'm the president of American Institute of Homeopathy, and we are very pleased to sponsor today's conference, a whole range of regarding the coronavirus. I'm going to review quickly the agenda. It's going to be a discussion of the historical epidemiological evidence for the good effects of homeopathy during epidemics, discussion of the proper homeopathic approach to epidemic disease, presentation of facts around the coronavirus, discussion of characteristic symptoms observed to date, and a discussion of the homeopathic treatment options, including homeoprophylaxis. And Dr. Sain will also explain how to take the case of patients presenting with coronavirus. So I have some announcements to make. First of all, I'm going to ask while you're here to keep yourself muted either on your computer or on your phone. This is going to be recorded. It will be up on the AIH website within a few days. I can't give you an exact time. I would say check the AIH website over the next 2-3 days. It should be up there. We are also instituting a data collection world about the coronavirus, its presentation, and its therapeutic treatments. And that will be up in a couple days. That's in the process of being set up. I can't give you an exact date. What will be required will be your name, your email address, and some other information, which will either be sent out by Peter or will be available on the website, how to make contact.
Ron, one quick side note there. If anyone wants to participate in this international database project of COVID-19 cases, they'll need to send me an email with their name, their email address, and their credentials, and I can then, because it's a secure website, I can then grant access. And we do expect it'll be ready no later than Friday.
Questions we're going to ask that all questions be held to the end. On the bottom of the screen, there's a place for chat. You can send your question to Peter Gold, who will then forward it to me, and we will, near the end of all the formal presentations, we will address questions. At this point in time, I'd like to introduce my friend and colleague, Ron Whitmont. And Ron, here you go.
Good morning and good afternoon, everyone. I do have the distinct pleasure of introducing our speakers today. So I'm going to introduce them all right now, rather than right before their presentations, so you'll know in advance who will be speaking. So we're starting out with Dr. Andre Sain, who is a 1982 graduate of the National College of Naturopathic Medicine in Portland, Oregon. He's also board certified in homeopathy in 1988 by the Homeopathic Academy of Naturopathic Physicians. He's been teaching and lecturing on homeopathy since 1985. He's considered one of the world's foremost experts on the subject of homeopathy, lecturing in Canada, the United States, and many European countries. He's also known as a homeopathic scholar, based on his in-depth studies of the work of the great masters of the past and based on his practice of pure Hahnemannian homeopathy. He's also a leading expert internationally on the historical, epidemiological evidence for the effectiveness of homeopathy during the epidemics of the last 200 years. One of the main points of his clinical work is the homeopathic treatment of patients suffering from very serious chronic diseases. Next, I'll be introducing Dr. Jennifer Jacobs, who's an MD and an MPH, and is a past president of the American Institute of Homeopathy and a clinical assistant professor in epidemiology at the University of Washington School of Public Health. She has published groundbreaking homeopathic research in peer-reviewed medical journals and is the co-author of the book Healing with Homeopathy, published by Warner Books in 1996. Her latest book, Do You Really Need That Pill?, was published by Skyhorse Publishing in June 2018. She's now retired from clinical practice and divides her time between Tucson, Arizona, and the Pacific Northwest. Next, I'll be introducing Dr. Dan Cook. Dan is an MD. He graduated from Stanford University in 1978, magna cum laude, from St. Louis University School of Medicine. And after studying homeopathy in Switzerland at the Zurich University postgraduate program of Dr. Kunzli, he began general homeopathy practice in Dallas, Texas, and is now in his 28th year. He was editor of the National Journal of the American Institute of Homeopathy between 2012 and 2014. He's published many articles on homeopathic methodology and history, and is currently the U.S. representative to the Global Federation of Homeopathic Medical Doctors, the Liga. And finally, I'll be introducing Dr. Martien Brands. He's an MD and a PhD, both in medicine, and he has been practicing as a homeopathic physician since 1988. Dr. Brands is the co-author of the Working Group in Epidemics and Disaster Management at the Liga Medicorum Homeopathicorum Internationalis, or Liga, and is also the president of Homeopaths Without Borders for the Netherlands. He has dedicated a major part of his career to studying the use of homeopathic medicines in epidemics. Dr. Brands has been a frequent lecturer at the Academic Medical Center at the University of Amsterdam and a senior clinical lecturer, assistant professor in Liverpool from 2002 to 2007, as well as a lecturer at various Dutch universities for many years. That concludes the introductions.
Thank you, Ron. And now, Andre, I will turn it over to you to begin your first presentation.
You're unmuted. Go ahead, Andre.
Yes, I'm trying to get my screen going. Thank you, Ron. My part is about the epidemiology of homeopathy, the history of it. So I welcome everybody to this lecture. Likely, the most compelling evidence for the effectiveness of homeopathy is found in its extensive records in times of epidemics. The homeopathic literature is very rich in reports on the result obtained by homeopathic treatment during time of epidemic. So close to 10,000 references have so far been found. The main finding of this review, of this vast review of the literature, is that result obtained by homeopathy during time of epidemic consistently reveal, just a second, consistently reveal an extremely low mortality rate. This observation holds true. This observation holds true regardless of the physician, the time, the place, or the type of epidemic disease, including disease that are known to have a very high mortality rate, such as cholera, smallpox, diphtheria, typhoid fever, yellow fever, and pneumonia. I will now present a few striking examples to illustrate this consistency of astonishingly low mortality rate. It is well recognized that infectious disease have often made more casualty among armies than combat, and have thus shaped the destiny of nation more than any other factor or general. Napoleon left France in June 1812 to conquer Russia with 600,000 soldiers, and only 3,000 were still alive 1 year later. It is estimated that he lost 220,000 soldiers solely to epidemic typhus in his first campaign to conquer Russia. In 1813, in his second attempt to conquer Russia, Napoleon retreated with his army to the city of Leipzig, where he was surrounded by the Allied armies and where the largest battle in European soil would occur prior to World War I, what became known as the Battle of the Nations. Incidentally, Dr. Samuel Hahnemann, the founder of homeopathy, was living in Leipzig during its siege in the fall of 1813. Typhus became thus epidemic in Leipzig, and every physician was obliged by the authorities to be in charge of a makeshift hospital to treat its population infested with epidemic typhus. In general, mortality from typhus tends to exceed 15%, but can be much higher, even up to 100%, in a famished and stressed population, as it was the case in Leipzig during its siege. In this makeshift hospital, Hahnemann treated 183 such cases without losing a single case, while the mortality under the ordinary treatment was considerable. He wrote, of 183 cases treated by me in Leipzig, not one died, which created a great sensation among the Russians, then ruling in Dresden, but was consigned to oblivion by the medical authorities of Germany, of course. When cholera entered Europe for the first time in 1831, Hahnemann predicted which remedy would be indicated for the different stage of the disease. His prediction turned out to be true, and millions of people benefit from his advice, as in all parts of the world where that were visited by cholera in the succeeding decades, and where homeopathy was applied, homeopathy came out with flying colors by decreasing the death rate by an average of about 50% down to 1 or 2%. In a well-documented epidemic of cholera that occurred in Cincinnati in 1849, 2 homeopathic physicians published daily in the public press the outcome of the treatment, which brought national attention. By the end of the epidemic, they had treated 2,646 cases with 35 deaths, a mortality of 1.3%, while allopathy has lost, according to the report of the Board of Health, nearly half of their case. These truly extraordinary results were obtained despite the fact that a fair number of patients were in a deep state of collapse, as well as many others had been mismanaged by practitioners of the conventional school of medicine. A third example. During the middle part of the 19th century, a most virulent form of scarlet fever, known as malignant scarlet fever, affected many communities in the eastern part of America, where it became the leading cause of death among children. In Carlisle, Pennsylvania, the homeopathic physician Adolphe Lippi reported having treated in 1849 over 150 cases of malignant scarlet fever without a single death, while the death rate under conventional medicine was over 90%, and the survivors were crippled for life. Such results are truly extraordinary, considering the fact that malignant or septic scarlet fever is the most severe and usually fatal form of scarlet fever, where infection becomes overwhelming, leading to septicemia, circulatory collapse, shock, and total organ failure, and some patients being described as rotting alive. The fourth example is about an epidemic of malignant diphtheria that affected large community on the eastern seashore of the United States between 1859 and 1862. 3 homeopathic physicians in Philadelphia reported having treated close to 300 of fully developed cases of malignant diphtheria without a single death in the winter of 1860, while the mortality under conventional medicine was over 50%. The least we could say is that these few examples of the extraordinary results obtained by homeopathy in times of epidemics are powerful illustration of a remark made by Nobel laureate Sir Ernest Rutherford. Quote, "If your experiment needs statistics, ought to have done a better experiment." Let's now focus on the COVID-19 epidemic, a flu-like illness that is precisely the subject of this webinar. When people die from flu or flu-like illness, 98% of these die from pneumonia. Despite all the advances made in conventional medicine, pneumonia remains today a major cause of morbidity and mortality, even in developed countries, especially in developed countries. Globally, pneumonia kills 1 million children younger than 5 years old each year, more than AIDS, malaria, and tuberculosis combined. The World Health Organization estimates that in developed countries, 1 in 3 children die from or associate with acute respiratory tract infection. We will therefore focus our attention on the outcome of the comparative treatment of the pneumonia patient. All cohorts of 5 or more cases that could be found in the conventional and homeopathic literature on the outcome of patients with pneumonia in a mixed population of ambulatory and hospitalized care during the same period of time and in the same part of the world have been tabulated, as you can see here. So here we have PAA, which means pre-antibiotic allopathy. Expectancy means no treatment is given. Unfortunately, the whole screen is not present. We're not able to see the bottom of the slide. So I will have to tell you what is the bottom of the slide. I cannot see it myself. So here with the pre-antibiotic allopathy, mortality rate 24.3. Expectancy is when patients are just watched. No treatment is given. They're given a warm room, fresh air, water, but no treatment is given. And the mortality was 21% in about 4 different experiences. All of them came around 21%. So the conclusion we could say that allopathy did not help and maybe even hurt 3% of the patient. Current conventional medical care, when it's limited to community-acquired pneumonia, is 13.7. Homeopathy in general, which is at the bottom of the screen, is 3.4, but lower than this is another part of the slide that we cannot see right now. It's called genuine Hahnemannian homeopathy, and the mortality is 0.4. So when we limit homeopathy to only genuine Hahnemannian homeopathy, it comes down to 0.4. So a very, very low mortality rate. So now let's look at the odds of surviving community-acquired pneumonia under pre-antibiotic allopathy, conventional, current conventional care, all way of practicing homeopathy, and general homeopathy. So it's 3-to-1, 6-to-1, 28-to-1, 231-to-1. Just stunning. Now let's look specifically at the 1918-1919 influenza pandemic, also known as the Spanish flu, which was associated with an estimated 50 to 100,000 million deaths worldwide. An estimated 675,000 American, or 0.7% of the US population, died from influenza during this pandemic, 10 times as many as World War I, and was even more deadly than the American casualty in World War I, World War II, Korea, and Vietnam combined. An estimated 43,000 service persons mobilized for World War I died from influenza, or half of the American soldiers who died in Europe during World War I. The table, this table shows a comparison of the result obtained by homeopathic physician during the fall and winter of 1819 with one of the largest statistical report for the U.S. Armed Force, namely the one with the lowest mortality rate that was done, because the U.S. Armed Force made several reports, some higher mortality rate. So I took the one with the lowest mortality rate. So of all the people that got the flu during in the Armed Force during the fall of 1918, there was a 5.8 mortality. The homeopathic physician who treated the general population during the fall and winter of 1918, 1919, they had a mortality of 8 times less, which was 0.7%. Now, if we look at the comparative mortality among the pregnant women who were the most susceptible case segment of the population during that epidemic, under conventional care, 30% of pregnant women died die under conventional medical care, where on the homeopathy, again, the death rate was very, very low. It was 0.7. So here is the combined effect of influenza and pneumonia. So not differentiating pneumonia. Now, if we look at the percentage of women that develop pneumonia in the allopathic contingent, it was 51%, while it was almost 10 times less in the homeopathic group. Now, if we look, now, if we look at the odds for the pregnant woman, so here under conventional care, the odds of dying were 1-to-1 under homeopathy for the pregnant woman. No, I'm sorry, not to die, to develop pneumonia was 1-to-1, and for homeopathy was 17-to-1. Now, when all the confounding factors are examined, including expectancy, the result obtained by general homeopathy in the treatment of the pneumonia patient demonstrate that the robust epidemiological and observational evidence clearly established cause and effect between the homeopathic treatment and the recovery of health and saving of life. The result obtained by homeopathy during epidemic cannot be explained by the placebo effect. The treatment effect of homeopathy is positive. The magnitude of the effect of homeopathy is remarkable. Homeopathy greatly shortened the duration of the disease and the recovery without leaving patient weakened by the treatment. Homeopathy clearly saves lives. 21 lives were saved out of 100 cases of pneumonia during the pre-antibiotic allopathy era, and 10 lives out of 100 cases with pneumonia would be saved today. Homeopathy offered the safest and best outcome ever demonstrated by any system of medicine for patients with pneumonia, and therefore would receive the highest possible recommendation of any intervention for these patients in the perspective of evidence-based medicine. In other ways, A1 strong recommendation with high quality evidence. So what the implication for such recommendation would be since society valued the saving of life more highly than any other outcome, homeopathy should be the treatment of choice for people with infectious disease. Second, patient with combined influenza of pneumonia, from the combined effect of influenza and pneumonia, should request genuine homeopathic treatment. Clinician should offer genuine homeopathic treatment to patients with influenza and pneumonia. Fourth, policymakers should ensure that homeopathy is adopted as a standard treatment for this population of patients. Homeopathy is also I just want to point here that homeopathy is known to be safe and effective, and also cost-effective, homeoprophylaxis. In other ways, the use of remedy to prevent people from developing an infection. So the same remedy that will be used to treat the patient can be used to prevent people from falling sick. I will give just two brief examples here. In 1874-75, there was a major epidemic of meningococcal meningitis that devastated Brazil. Around 250,000 cases became ill, more than 11,000 deaths, and over 75,000 people were left with permanent brain damage. In one city, 18,000 children were given one dose only of a homeopathic remedy. The incidence of meningitis was 7 times less in the group that received homeoprophylaxis. A second example, In 2007, Cuba was in the midst of an epidemic of leptospirosis. In 3 high-risk regions, with a combined population of 2.4 million, 2.1 million received 1 or 2 doses of homeoprophylaxis, and the incidence of leptospirosis was significantly diminished, down by 84% in the treated group. In conclusion, infectious disease can greatly alter civilization and shape history. There will always be epidemics, and humanity will always be susceptible to them. All flu-like illness can evolve into pneumonia, which become by far the main cause of mortality from these illness, as close to 98% of people die from these flu-like illness from pneumonia. The current COVID-19 epidemic is a flu-like illness that severely affects the older and immunocompromised segment of our population. The epidemiological evidence clearly show that homeopathy discloses a very consistent and strong prophylactic and therapeutic effect and real-world long-term effectiveness, while is at the same time safe and cost-effective, and should therefore play a major role in the public health care system. Finally, the take-home message I want to leave the audience with is that no one should ever die from pneumonia under proper homeopathic treatment, regardless of the severity of the case and the associated comorbidity. As after 40 years of homeopathic practice and having treated over 250, maybe 300, maybe more, with pneumonia with perfect success, despite the fact that a great number of these were on the deathbed, whether the implicated microorganism was viral, bacterial, or fungal, and regardless of the severity of the illness, the underlying complications such as immune deficiency, heart failure, kidney failure, or meningitis, or the age of the patient as in centenarian, left for dying without any more treatment, or in patient with resistant microorganism. The answer to the question whether homeopathy should be tried seems to be obvious. As usual, I will leave my audience with some words from Samuel Hahnemann. How insignificant and ridiculous is mere theoretical skepticism in opposition to this unerring, infallible, experimental proof. Thank you.
Thank you, Andre. As always, incredibly thorough and clear and valuable. I'm now gonna, Jennifer, it's now your time to shine for us and educate us.
There we go. Okay, so what I'm going to be talking about today is the homeopathic approach to the prevention and management of epidemic diseases. The questions that we're going to talk about: what is the best homeopathic method to use on a widespread basis for epidemic diseases? And what is the best approach with this current COVID-19 crisis? So I've looked into the literature, and I feel like there's 4 main homeopathic approaches to epidemic diseases. The first, of course, is individualization, which is the gold standard of homeopathic treatment. The second is combination remedies. The third is the use of the genus epidemicus. And the fourth is the use of isopathy or nosos. When we talk about individualization, there are several remedies that have been talked about recently in the COVID epidemic. These are going to be talked about more thoroughly in a later part of the seminar, but I just wanted to mention them. Gelsemium, which has been mentioned in cases from Europe as well as China. Bryonia also has been mentioned from Europe and China. And arsenicum album is being used in India as prophylaxis, recommended by the AYUSH, the Indian government alternative medicine branch. They're recommending that people take 1 dose of arsenicum 30 daily for 3 days as a prophylaxis. I'm not sure how this is working out, but we are seeing that there aren't any cases reported thus far from India. Other remedies that could be used, eupatorium perf, camphor has been suggested by Sankaran, and sulfur and lycopodium are choices of Paul Herskew. The difficulties with individualization, of course, is the availability of qualified homeopathic prescribers, especially in a worldwide epidemic that we're facing right now. It's very expensive to provide individualized homeopathy. The accuracy of the prescription is always important, which you can't always count on. And the worldwide generalizability is difficult. So the next way that we think of is, oh, I've already done that. What am I doing? Okay, wait. Combination remedies. And I'm sure we're all familiar with these. They combine several remedies commonly prescribed for a specific disease into one medication. It could be a cost-effective and logistically possible in an epidemic like this to put together a homeopathic combination that contains the most likely remedies. However, I've looked online at some of the flu remedies from different companies, and I haven't seen anything that seems appropriate for COVID-19. Maybe some of other people might have found something, in which case they can share that later. There was a study using a combination remedy for dengue fever in Pakistan. They used a combination of 10 homeopathic remedies that were indicated for dengue fever symptoms, and they added that to standard supportive therapy at that time, which included fluids, acetaminophen, and medications for nausea and vomiting. They compared patients treated with these 10 remedies with those who received standard supportive therapy alone. And after 6 days, they found statistically significant improvements in platelet levels, which are important in dengue fever, hematocrit levels, and white blood count. They did not report any clinical symptoms, however. The problem with combination remedies, which is what we ran into a study that I led in Honduras, is getting the right combination. For this study, we used 6 remedies that should be appropriate for dengue fever. You can see them listed here. We followed the patients with home visits for 1 week to monitor their outcomes, which were pain and fever for the primary outcomes. And we found no difference from placebo in those who received the homeopathic combination. So this brings forward the important idea that the composition of the combination remedy did not match the correct remedies for the local epidemic. And that's why it's important to collect pilot data, some kind of data collection about the epidemic being treated, so that we can zone in on which remedies are the most appropriate if there were a combination used. The third way, of course, is what William Hahnemann, the genus Epidemicus. He wrote in Aphorism 102, for writing down the symptoms of several cases of this sort, the outline of the disease picture becomes more complete. The entire scope of such an epidemic can be distilled and gathered only from the sufferings of several patients with different physical constitutions. So some examples of the use of genus Epidemicus, of course, the famous first use of the genus Epidemicus by Hahnemann in 1798, where he used belladonna as a preventative for scarlet fever. In the Spanish flu epidemic of 1919, it's been reported that Semian was the genus Epidemicus. This was reported from several different authors who wrote about the epidemic. And an interesting study of genus Epidemicus was done in India on chikungunya fever. They brought together a group of homeopathic experts, I think there were about 20 of them, who analyzed 250 cases of this fever, and then they determined Bryonia was the genus Epidemicus. They then gave Bryonia or placebo to family clusters of about 200 people prophylactically, and they found that only 12.8% of those given the Bryonia developed illness versus 15.8% of people who did not receive the Bryonia. And this was statistically significant. Another example of looking for the genus Epidemicus was during the 2009 swine flu epidemic. This was a data collection that was done by 23 it included more than 1,100 patients, and the most common symptoms that they found were pretty generalized symptoms: fever, cough, and runny nose. However, the remedy that they found most commonly was arsenic amalgam, which was prescribed in 25% of the cases. I think this might be why they're using arsenicum now in India as a preventative. And one of the things they pointed out in the study, which we should think about for the data collection we're doing with AIH, is that they did not collect keynote symptoms, which would have been very valuable in terms of their understanding of what the genus Epidemicus should be in this case. Finally, the fourth method is using nosodes, mostly as a preventative, is what I've been finding in the literature, not so much as a treatment. A good example of this is a study that was done by Jonas on tularemia in animals. He potentized reticuloendothelial tissues from infected mice or placebo that were given 1 month prior, and then a lethal dose was given to all the mice, and the time to death and total mortality rate was measured. He found that all groups except those given a 1M had statistically significant decreased time to death rates, and the overall mortality rate was reduced by 22%. Andre already talked about the leptospirosis epidemic in Cuba, which is an excellent example of homeoprophylaxis, but I'll review it here. Nosode of 4 strains of leptospirosis.
Jennifer, can I ask you for
Yes.
1 second? Your internet connection has been problematic. If you turned off your screen sharing, it might improve the audio. Why don't we try that?
Turn off my screen sharing.
Yeah, and then just speak to the points you're making, because your audio may improve dramatically if we do that.
Okay, I have, okay. So how do
Actually, your audio is much better now. I don't know if you just changed anything.
I'm almost done. So can you hear me now?
Yep, very well.
Okay. So the leptospirosis epidemic in Cuba, a nosode of 4 strains were given in 3 provinces. More than 2 million were given 2 doses of the 200C, and then 1 year later, 2 doses of 10M. There was an 84% decreased incidence the following year in those provinces, whereas there was a 21% increase incidence in other provinces that were not given the dose. There is discussion about the validity of this data, however. Other reports of prophylaxis using nosodes. There's an article in the American Journal of Homeopathic Medicine by Golden about Japanese encephalitis and dengue fever. He reports effectiveness as 63 to 99%. And as far as the COVID-19 nosode, apparently there are some available in the US and Germany, but I have no idea what they were made from, anything about them, but that's something we need to know more about. So in summary, the 4 methods of homeopathic prevention and management: individualization, combination remedy, genus epidemicus, which we hope to contribute towards with the EIH data collection, and a nosode, which we're hoping might be available of COVID-19. Finally, a lot of the references for this can be found in this journal, and a free link to this article, as well as the one on the 2009 H1N1 data collection, will be available soon, and I'll have Peter let everyone know how to access these. So that's it. Thank you.
Thank you, Jennifer. As always, incredibly thorough, and I appreciate that. And now, Dan, it's your turn.
Unmute me. Nice to be with you. Coronavirus is a family of viruses common to many animals. The human outbreak of COVID-19 began December 2019 in Wuhan, China, at a wet market where many kinds of animals, birds, and fish are sold and butchered for human consumption. In the number of cases and countries, COVID-19 has dwarfed the spread of the last 2 coronavirus outbreaks, SARS and MERS. It's now in over 90% of the countries in the world, with 200,000 cases, 80,000 of which are now recovered, and 8,000 deaths as of yesterday. 12 new countries reported cases in just the 24 hours between March 13th and March 14th. In the US, there are 6,700 cases with 120 deaths, led by California, New York, and Washington. What is it? It's a flu-like illness with a high risk of complication with pneumonia, high fever, dry cough, lethargy, shortness of breath. Muscle aches are common. Sputum production can occur. Dyspnea seems to develop usually 7 to 9 days after symptom onset. The great concern is twofold. COVID is twice as contagious as seasonal flu, so that 1 person spreads to 3, while the factor for seasonal flu is 1 to 1.4. And the mortality rate is 10 times higher than seasonal flu. Mortality rate currently is 4% for COVID-19, but with wide variances between countries. Some European countries are under 1% currently. Seasonal flu in the United States has a mortality generally of 1/2 of 1%. So in the United States, it is 10 times deadlier than flu, and especially for the elderly. The mode of transmission is by mucus droplets, either in the air from coughing or on surfaces, because the virus can maintain intact existence on hard surfaces for at least 2 to 4 hours and maybe quite longer. So contacting a surface with your hand and then touching your face is a mode. Incubation period is between 48 hours and 12 days, with most showing symptoms within 4 to 5 days of exposure. Shedding does happen in the prodromal asymptomatic phase. And if the patient has GI symptoms, fecal shedding occurs. There are growing reports of essentially asymptomatic cases who lacked the cardinal symptoms of fever, cough, and shortness of breath, and who continued to go to work or go vacationing with friends, and were therefore transmitting carriers. The time to shortness of breath, it's unclear yet, but appears to be about 6 to 8 days. 80% of COVID patients are mild cases, 20% need hospitalizations, of whom 5% need ICU care. In one Chinese study, the average hospital stay was 22 days. Cough may persist for more than 20 days. Who gets it? All ages. To this point, there's a very low incidence in the young under age 20. High-risk patients include those with heart disease, lung disease, diabetes, and just defined in the last 3 days by CDC, anyone over the age of 60, which makes 100 million Americans high risk by definition. How far will it spread? The German chancellor said that up to two-thirds of the country in Germany would be infected. Some say that 30 to 40% of the globe will get this disease. What are the current treatments and goals of conventional medicine? Preventive treatment is three-pronged. Hand washing removes the lipid coat and terminates virus activity, so do a 2-minute wash. Cover your mouth when you're coughing. Don't go into crowds, where some people standing or sitting near you may themselves have recently contacted someone who is carrying and shedding COVID. A state of emergency has now been declared in many states, restricting gatherings to less than 250, and some places less than 50. Medical treatment is supportive care, including oxygen support. The national goals are prevent transmission chains. 5 to 10% of people who have contact with a patient having COVID-19 will acquire the disease. So the national goals are find cases as fast as possible and isolate them. Follow their contacts and investigate them. Since shedding a virus can happen in the 48-hour incubation phase, contacts in the 2 days prior to first symptoms will be checked and quarantined. This will slow the epidemic, slow the doubling time so that it does not multiply so quickly, but it will not stop it. Who to test? At this point in the United States, with tests in short supply, the recommendation is to test those with high probability of having COVID-19. So the rest of my time, I want to discuss how, as healthcare professionals in this country, we officially identify patients as suspected COVID patients, where we treat them, and how to take care of our offices and office staff. Identifying a suspected case, which is an acronym in US as PUI, person under investigation, depends on 2 criterion: symptoms and exposure. Fever alone in a patient with no cough and no sore throat will qualify a patient as a suspected COVID-19 case if that patient has close contact to a confirmed COVID-19 case within 14 days of symptom onset. Close contact is being within approximately 6 feet or 2 meters of a person with COVID-19 for a prolonged period of time, such as caring for or visiting the patient, or sitting within 6 feet of the patient in a healthcare waiting room, or having unprotected direct contact with infectious secretions or excretions of the patient. That includes touching a used tissue with your bare hand. If you have fever, a patient has fever with cough or shortness of breath and a history of travel, they are by definition a person under investigation or a suspected COVID patient. Up until 8 days ago, there were countries listed as level 2 or level 3 places that we needed to be concerned about. At this point, it is listed as a global outbreak. Every country in the world, every state in the world has a CDC level 2 or 3 travel health notice, so anyone traveling is in this category. The third criteria, if someone has fever with cough or shortness of breath and is so ill that they need hospitalization, they are a suspect COVID case until proven otherwise, even without a history of exposure or travel. What should patients do who have mild symptoms such as light fever and runny nose, or cough without fever, and no known exposure? Just stay at home. It could be a cold or a light flu. If the patient calls you, a physician, with mild symptoms, encourage them to stay at home, monitor their temperature, and call you back in 24 hours. Now, how to treat a patient who is a suspected case. Patient calls your office and meets the criteria for a suspected case. What do? First, mandatory notification of the state or local health department. This sets in motion the search for additional contacts, which is the main official way of containing this disease. There is a PUI case form that then is filled out by the health department, and they start locating contacts and quarantining them. A good idea for the practitioner is to categorize suspected cases as mild, moderate, or severe. Do they have high fever? Do they have shortness of breath? How fatigued are they? Do they have a chronic illness? Mild cases can be treated at home isolation, which is stay home, stay away from others, even pets. Wash hands frequently, wear a mask around others, clean surfaces frequently, stay in touch with your physician every 24 hours. Moderate cases should be seen in a clinic, and if there are severe cases, you send them to the ER. So let's say a mild case of someone who is a suspected COVID case that you spoke to on the phone yesterday, calls today, they are sicker, and they call your office for an appointment. Your office has to be prepared with personal protective equipment, isolation room for the patient, and proper sanitation procedures. These are: the patient must wear a mask in your building. In the medical office, they have to keep 6 feet distance, or preferably a separate room for that suspected patient. There should be a handwritten notice for the patient to observe hygiene procedures: mask, hand sanitizer, limiting surface touch, use and disposal of tissues. There should be alcohol-based hand rub with 60 to 95% alcohol, tissues, and no-touch receptacles for disposal at the entrance and waiting rooms and patient check-in areas. All staff contacting the suspected patient has to wear gowns, gloves, and face masks. Recommendation is for the N95 respirator, but see if you can find one these days. They're in very short supply. Clean all frequently touched surfaces with an approved hospital disinfectant cleaning agent, and I'll show a list of that at the end of the presentation. When a suspected COVID patient is in your office, you must establish risk assessment to yourself and to all office staff who interact with the patient. There is a detailed CDC interim guideline, which I will show at the end, but the main factors involved in this risk assessment include the length of exposure, the amount of aerosols produced by the patient, by cough or sputum, and whether the patient, as well as the healthcare worker, are wearing proper face protection. If, when you do this assessment, the healthcare worker is determined to be at medium or high risk exposure because of lack of protection, 14-day quarantine is mandatory, and you will be tested twice during that time for the disease. And now, Peter, could you show that page of references? So we have at the first, these are basically CDC guidelines that are updated each week. Who to test, how to clean your office, EPA recommended disinfectants, study on clinical characteristics in 1,099 patients. The case report form that is mandatory to be filled out by the health department, in which when any patient meeting the criteria for a person under investigation needs to be informed. And then an update map that is updated daily from Johns Hopkins University. Thank you for your attention.
Thank you, Dan. Incredibly thorough. And again, I say this to each panelist, but I'm just always impressed by the thoroughness and clarity of information that we're getting. It's now time for Andre, for you and Martine to discuss characteristic symptoms observed to date.
Yes.
And I'll let you guys decide how you're going to use each other's time.
Well, I can begin, Martin, or you want to begin?
Well, I would propose that we decide which are the main things we want to discuss right now. My proposal is to see how to record the main symptoms,
Okay, so maybe I'll go with I'll let you finish. I'll go with the symptom that we have seen so far, and then you could talk about how to record them.
Yeah, good.
Very good. Okay. Listen, I have reviewed the literature on COVID-19. You don't see my screen right now, right? So I'll
if you share it, yes, would be nice.
yeah. Okay, very good. You see my screen right now, right?
Yes, yes, I do.
Very good. So I looked at the cases that were published in the literature, like this, many articles, and I look at self-described cases, people describing this symptom. I look at cases that were reported from Iran. I look at cases that I've treated with the flu in the last month, including 3 in this last 5 days or 6 days, with shortness of breath, fever and shortness of breath, and pneumonia. And the symptom that we have are these symptoms, but that does not individualize the patient. You just say these are the symptoms that have been reported so far in patient with COVID-19 or the current flu that is running around right now. What I can say is we don't have enough experience with clear, good homeopathic case to say, oh, here we have the real picture of the disease. Regardless, if the picture of the disease came from a certain country, it might not be the same in another country. Picture of a disease or the genius epidemicus could change from being on the seashore versus being in altitude in the mountain, or in a dry climate versus a wet climate. So it will change from one place to the other. So if I had to make a bet from my own experience, from what I've seen so far, from my cases in my practice for the last 2 months, I would say that the most likely remedy, that the one that seems to be the most common remedy to come to the surface, is brownia. So if I would show you the most often remedy called in patient with pneumonia, not necessarily relate to influenza, but just for pneumonia in general, these would be the one that I have seen and you read also in the literature. So from my own practice and from the literature, these are the remedy in order that are most used in patient with pneumonia. So brownia is second in any case. Yesterday, I saw a patient with lymphoma that had pneumonia, and she had the fever and so on, and she responded right away to sulfur, and her oxygen saturation index went from 92 to 99, I believe, in about 2 hours. So she was just going down with shortness of breath. And which is a very, very common prescription. Another thing I want to point out is that half of the patient that needs a remedy during pneumonia might be different than the pre-stage when they have flu. So when they have the flu, yes, it could be gelsemium very commonly. It could be also brownia with the flu, but when they go into the stage of pneumonia, the picture may change. And it's important to point out here that the stage of the disease are very important to address. And let's look at this right now. So here we have the different stage of the disease. So I cannot see it myself. Okay, very good. So here we have the first stage with the congestive stage when there is an inflammation. And then there is an effusion. So it's called the secondary consolidation stage. So this is the same, secondary and consolidation. And then if the person survived the second stage, that's if when you make it or you could die, then you go into the resolution, that when the fluid are reabsorbed, and eventually people can remain sick for a long time, or be very convalescent for a long time, or remain weak for a long time. Because here, the people that develop pneumonia and very, very severe type of pneumonia, and they go in a state of collapse, we have to pay attention to inflammation in or pneumonia in people, in old people. So this rubrics must be very, very well understood. And there's another one for epidemic, that means pneumonia that tends to be seen very often during when there's an epidemic. Could be a group. Brownia would be one of them. Cuprum would be another one, and I believe Ferrum metallicum would be the 3 remedy. when you have a case with rapid onset, so that's always also very important to pay attention to. Aside from the stage is the quickness of the progression. And then you have all kinds of peculiar symptoms that you must pay attention, that would address a lot of the cases that have been published right now. People go in a state of unconsciousness with pneumonia very, very quickly. And here you'll notice one of the remedy, so yeah, phosphorus here. So people can go in a state of collapse very, very quickly. So you have to pay attention to this. These are very, very good, a very good symptom to, a very good rubric when people are in the late stage of shortness of breath. You must pay attention to this, to the nose and this symptom. It's very reliable, very useful. If there's nausea and vomiting, there are remedy indicated when people have pneumonia with nausea and vomiting. When people are in have lung collapse, that means paralysis, they cannot breathe, there's too much congestion, or they're just too old to make an effort anymore to breathe, you have to look at these rubrics here. So,
Andre, if I can interrupt you for 1 second, I apologize, getting some questions that I think are pertinent. A lot of the folks are saying that the chances of any of us seeing patients in this state are fairly remote. What are the symptoms, characteristic symptoms you're seeing that, for those less acute cases, but those showing symptoms that would lead you to bryonia?
So Brian is very, very easy. The patient wants to lay down, doesn't want to move, has difficulty breathing, and may have pain, but movement is not pleasant. And one of the characteristics is they will, first of all, they will be worse for motion, but if they have pain, they want to put pressure, but they must be thirsty. If they're thirstless, unlikely it's bryonia. So then if they're thirstless, you go right away, you think of a gelsemium, which would be also a first stage remedy. If we look at the stages here, I lost my representation. So if you go in the first stage, okay, so let's look first stage, a congestive stage. So you have here the gelsemium, and you have also bryonia in the first stage. So yes, it would be a remedy, it could be used. Why it's important to look at these remedies? Because you may treat somebody with the flu, but they may also go quickly into pneumonia. So before you call 911 or the patient gets there, you may have to prescribe for these type of symptoms.
Andre, I need to give you like a little 2-minute notice so we have time for Marty and.
Okay, very good. Okay, very good. I'll do that, right? I'll do this. So you pay attention to the stage, you pay attention to the age. A baby, pneumonia in children will require other remedy. For instance, like Ipecac is very, very common prescription in infant, and so is Chelidonium. The other, if I come back to my list of remedy here, so there was the most used remedy. These are least used remedy, but they could be sometimes the genus epidemicus of an epidemic. For instance, Cuprum metallicum. Where is Cuprum? Cuprum is your Cuprum metallicum was the genus epidemicus in the state of Connecticut during the 1918-1919 flu pandemic for people in late stage pneumonia. Almost every case respond to this. Another point I want to point out is for the flu, there might be a genus epidemicus, but when they go in the state of pneumonia, it may change. The genus epidemicus may change, or the remedy might be needed will change. And be aware that 50% of the remedy that the patient that will need a remedy during pneumonia is the chronic remedy they need. So it's very important to understand. So once they've passed the state of chills and fever and malaise, they may go into pneumonia, and then the remedy may change to their chronic remedy in 50% of the case. Finally, when you have a patient with flu and pneumonia, they will have so many symptoms that it will be hard not to have a clear case, because you want to have all the symptoms that will differentiate one remedy from the other. So you look at the location. So in pneumonia, look at where the pneumonia is located. It always starts, or typically starts, on one side. In COVID, it's bilateral diffuse pneumonia, but it usually will start on one side. the location of if they have pain or something like this, you always pay attention. And cough will give you a lot of modalities. So it's very, very useful to differentiate one remedy from another. The expectoration, the type of expectoration, especially the taste can change your case around. The malaise, you pay attention to what makes the malaise better or worse, movement or rest or pressure or no pressure.
I hate to be the policeman here, so I'm not
Yeah.
going to be a policeman. I'm just going to.
I have three more things to say. Disposition of the patient is also very important. Thirst is crucial, and intercurrent symptom. So whatever symptom that comes with it, headache or whatever, nausea, diarrhea, you all pay attention to it, and it should not be difficult to treat people with pneumonia. You just have to make a good differential diagnosis. I'm done.
Okay.
Thank you. Thank you. Martien, now your turn to educate us.
Yeah, well, first of all, thanks, Andre, for this these different symptoms. While listening to you, I notice, and this is my great concern, looking at from, let's say, public health perspective, that we need to make a distinction between the different levels people can practice homeopathy, and it depends on their previous training, depends on their expertise in clinical decision making. So I would suggest that we spread clearly the message that most of this case analysis which you did refers to advanced practicing, advanced practice. That means people who have many years of experience in distinguishing between these symptoms, which is most probably only the top of the pyramid of healthcare practitioners in homeopathy. Below that advanced care, I would suggest that when we go to the level of problem-oriented practicing, that we develop an algorithm for which the symptoms which you just mentioned could serve very well, like the typical sensations someone has, the locations, the concomitant symptoms, the modalities, which can help people go through these algorithms with posing the most relevant questions. The level below that, that's the basis of the pyramid, is for people with less experience in homeopathy, but who still see patients, and that could be communicated to a wider professional audience. And then I come back to what Jennifer said about the genus epidemicus. In India, there are plans now to do a pilot study for genus epidemicus, which need to contain at least 50 or preferably 100 patients, according to the early instructions from Hahnemann, to establish in that area. So it might be context bound, it might be not global what comes out, the most important remedies. If I shared with the group who prepared the seminar the Lancet paper, which describes very clearly the symptoms, and I also shared the repertorization which has been made in this Indian group. There it was analyzed by McRepertory that bryonia, phosphorus and arsenic came out as the top 3 remedies, which cover indeed some very specific aspects of the COVID clinical manifestation, like the dry cough and the pneumonia and the malaise and exhaustion. So these remedies might be the best ones to use on a level that you are not trained or not feel capable to, and I think it's very wise to acknowledge your limits when treating patients with this horrible disease. They might be given more rapidly, handed out to a larger public. And I'm also thinking not only of, let's say, upscale practices in the Western countries, but also in developing countries where often highly trained professionals are not available. So coming back to this pyramid, I would also suggest that when we are treating as medical doctors, and then we can consider us within the problem-oriented or the advanced level of practice. I would strongly suggest that we make clear limits until when we consider it safe to treat patients in an ambulatory setting. At this moment, outside of India and Brazil, there are no homeopathic hospitals which can combine homeopathy with a clinical context of treatments. So I would suggest to respect the cutoff points which the WHO has given for when to refer someone to medical treatment. And I would say that we better follow these guidelines rather than experimenting ourselves when we are not completely sure what to give. And when we see that the genus epidemicus is not working within, let's say, a few hours, and we do not need to expect the stage that someone gets dyspnoic, the moment that we think we need to give remedies for dyspnea, I think we are already crossing a border in terms of triage. I think then we should refer someone immediately to a hospital to get treatment there, because the dyspnea can be the first sign of beginning pneumonia, and I don't want anyone to die going home being given some homeopathic remedies. This would be first of all, I don't think it's unethical when we do not have the clinical setting to hospitalize someone immediately, and I also think it's a very bad publicity for homeopathy. I don't think we need to prove that homeopathy has a right to exist in the homeopathic healthcare. I simply think we need to support people where we can, and this puts a limit on our efforts, because we are not having hospital settings at our disposal in most of the Western countries. So I think we better be modest than trying to be the best. And to finish with quoting one of the best architects in the world, Mies van der Rohe, who said, "Less is more." And I would recommend that as a guideline when we practice homeopathy. Okay, that's it.
Martin, thank you. Thank you for your words of wisdom about scope of practice and decision-making. I agree with you. We don't need to prove that homeopathy works. We also don't need to, we need to be careful, because the most important thing as physicians and providers is the care of the person at the time, of course. Did you want to say something else, Martin? Yeah, unmute you, Shel. Unmute you. Okay.
Yeah. Okay. Sorry, I forgot to say that if we want to collect data, we could maybe attach the database which we have prepared to the AIH site, which is shown here. Do you see my this? No, I shall share it for the screen. You see this now?
I think the best thing would be for us to include in the whole package of people offering data. And I think that will come in a couple of days. I think it's going to be up, Peter, correct?
That's correct.
Okay.
Yes. So if you're watching and thinking, oh my God, I need to photograph this or something, you can just relax. It will be available.
Sure.
The whole data
One quick point to make on that: when the tool is finally set up inside the website, when people enter case data, they'll see a slightly different version of this form. So it won't be exactly as you see it here in this screenshot, but it'll ask for the very same information.
Just for the illustration then now, in this way we can have each practitioner recording the patients, and also per patient record several consultations, and it's up to anyone when they need more consultations, and especially pay attention to the duration of the symptoms, as we know that is an important parameter to estimate the course of the disease. The main clinical symptoms as they have been identified in the Lancet paper, other medical conditions, other treatments, and then anyone who wants can go further and noting the homeopathic symptoms as well. But at least this can function as a basic tool to record your patients presenting with this disease. And I will leave it with that.
Again, thank you, Martin.
Yes, you're welcome.
So now, Andre, the next part of discussion of homeopathic treatment options, which I think you had touched on already, as well as homeopathic prophylaxis.
Yes.
Thank you, Ron.
You're welcome.
Okay, very good. Listen, for homeopathic prophylaxis, the best is to find the genus Epidemicus. The genus Epidemicus would help to prevent people from contracting the flu. So this would have to be done in different localities. Once you have a 5-10 patient, you may start to have a glimpse of the genus Epidemicus. And like I said before, the genus Epidemicus may change during an epidemic by a change of climate. It will change in altitude. So if the lower part of a city by the river would be different than up in the hills by the ocean, dry, wet climates. So we have to be aware of this. But the genus Epidemicus in the locality should, once it's found, should prevent everyone from getting the flu that is contaminated to develop a symptom. So this is something that could be important. Okay, so this is for finding the genus Epidemicus. What was the other part, Ron?
Is it's got homeopathic treatment options, including homeoprophylaxis, and you also how to take the case.
Okay, yeah. So
COVID.
you know, all the cases I've seen by colleagues that were published, they're very incomplete case. A complete case of a patient with the flu, it's not difficult to do. You take all the symptoms of the flu, but you have to get also all the modality that they have. So all the concomitant and all the modality, and you try to differentiate constantly what makes things better, what makes it worse. For instance, the cough. The cough is a great way to find a remedy. And then the sputum, and then you look at the chills, the sweat, and so on. So every symptom must have modalities, what makes it better or worse in times. And so when you have the whole picture of the disposition of the patient, the thirst of the patient or lack of thirst of the patient, about their malaise, about their energy level, and all other type of indisposition. Let's say, for instance, shortness of breath. People may have shortness of breath. Then I do that all the time, every day on the phone. I say, okay, now go. I say, when is the shortness of breath better or worse? I don't know. Okay, so go lay down, go flat without a pillow. How is it on the scale of 10? 6. Okay, put 2 pillows. 5. So it's better with the head high. Okay, let's now sit. What is it sitting? 4, so it's better sitting. Try standing. 3, so it's better standing. Start to walk. Much worse, so it's worse walking. So you do these things, and very quickly, within a few minutes, you can get a good picture of the remedy. I believe, from my clinical experience, that we could write a little booklet that would be less than 50 pages, that could be associated with a kit with about 50 remedies, that could be distributed in every hospital of the world, in every village of the world, on instruction for people that don't know homeopathy, but how to use the remedy. Very, very simple. We could do just a 1-hour webinar on how to use this little booklet and little case, and we would save a tremendous amount of people that have pneumonia, especially like children in the less developed countries. So it's not really difficult. So when Martin says, yeah, but you're talking about high level of homeopathy. No, I would say it's basic level of homeopathy to take a complete case, to say what is most characteristic symptom of this case. Then you say, you take this totality, which is the genius of the disease of this individual, and then you look in the Mathematica and says, which remedy fits best? It's very easy when you have a good software. You just look pneumonia. If you think the patient needs chelidonium, you just type pneumonia and you look under chelidonium, where the Mathematica on pneumonia would be it would be in a hearing or Lilienthal. They will give you a good description, and then you see if it fits the case. Then the remedy must be prescribed in a potency that would be proportional to the severity of the disease or how quickly the disease is advancing, and the repetition must also be adapted. So that's another point that could be discussed at another time. And then you must do a follow-up. The follow-up is not next day unless it's 10:30 at night or 11 o'clock. It's in 1 or 2 hours. So in 1 or 2 hours, the person should be able to tell you if they have taken the remedy, how is the shortness of breath, how is the energy, how is the pain, how is the sputum, how is the cough. They should tell you, and you would know right away if it's the right remedy, and you would know right away how to continue to prescribe the remedy. I always ask the patient.
May I say something, and Andre?
Yes.
May I interrupt you? I appreciate your zeal for practicing homeopathy on this level, but let's say the instruments you name, like the repertory and the materia medica, that is it's like talking as on the level of Roger Federer, who knows all the ways to play tennis on an advanced level, and explaining that to a young kid of 10 years who just started. And I don't want to sound arrogant, but I think there's a huge difference between our level of thinking of practicing homeopathy and what many people are capable of doing. So we need, I would rather say, let's try to use this opportunity to make homeopathy doable, feasible for larger amounts of people, but then we need to give them the instruments which correspond with this, let's say, 10, 12-year-old boy who wants to learn the basics of tennis, rather than saying that how you should make a smash or a serve of 200 kilometers per hour, because they will not succeed and they might endanger their patients and they will be disappointed with homeopathy. So why don't try to work the coming days or weeks to make a good algorithm from the symptoms which you just mentioned, because I kept on making notes while you were talking, and I think there is plenty of space for that.
Sure.
Well, this is George. I don't know if you can hear me, but I would like Andre to go on, because I believe there are many of us who are capable of applying this, and this has to be applied to develop an algorithm. So, you know, you need prescribers to find the effective remedy or remedies, and then you can make the algorithm for those who maybe lack the expertise. So I would vote to keep going, Andre. Thanks.
Thank you, George. Martin, listen, I hear your point for sure. However, I'm not speaking to any particular group of homeopaths. I'm talking to the general world community of homeopaths. So some people may have the practice of homeopathy. It's like going to grade school. Grade 1, you learn the letters. 2, you make words. Grade 3, you make sentence. Grade 4, you make paragraphs. So not everybody can write a chapter or a book or many books. So, but you can. You can raise the level of people too. But be aware that when Hahnemann gave his instruction of how to deal with the cholera epidemic, it was very brief instruction, not very long. There were physicians in different parts of the world that only took his instruction, and from there they saved thousands and thousands and thousands of lives.
And that's
Very simply.
that's exactly why I advocate, and I hope the facilities are there in India to rapidly make an genus epidemicus, which can be shared worldwide. And if it doesn't work, then there are people who can work like you just described. Because again, I think we need to be aware that there are big levels, differences in levels of practicing and expertise.
Okay. The other point I would like to make is the following. Nobody can predict how an epidemic goes.
No.
Nobody can predict. It can wave or wane and wax and so on. Nobody can predict it. During the 1918-1919 epidemic, there was 3 waves. A wave would last about 2 or 3 months. It would die out and it would be gone for maybe 3, 4, 5 months, and then there would be another wave that would come. And the second wave is more deadly. We don't know how this epidemic will go. We don't know how the virus will mutate. We don't know how many people will be sick. We don't know how hospital will be overwhelmed with patients. We don't know how much homeopath will be involved in treating the community, and we could be highly involved. We don't know where it's going to go, but I want to say that the point I want to make is it's rather easy to treat people with the flu and pneumonia, and every person that has a basic knowledge of the technique of homeopathy should be able to achieve very, very high results if they follow a very simple methodology.
That's exactly why I'm advocating to use that way.
Yeah,
then empower people.
Treating each individual as individual, taking a complete case, the totality of the symptom, and you say from these totality, what is the most peculiar symptom of this patient that this patient is presenting? You take these group of symptoms and to say, this is the genius of the disease of this patient. What in the Mathematica is like this? It's A, B, C, and D processes.
Andre, let me interrupt for a moment. I think Dr. Brands is maybe speaking to the larger population again. Dr. Brands, correct me if I'm wrong, but if we can, as a community, come up with a handful of remedies that seem to fit the greatest number of cases, we can give the larger community outside of the homeopathic community a sense of a cluster of remedies to look at and symptomatology to attach to each remedy, so that they on their own can begin to improve the health of the loved ones around them. Dr. Brands,
I want to refer to the worldwide known book Where There Is No Doctor. And there's only, if we talk about a pandemic, we need to be prepared as a homeopathic community to hand out instruments for the cases that there are no homeopaths around, but people still want to use homeopathy, because for the coming year, I predict there will be no vaccine, there will be no medical treatment in an allopathic sense. So I think we have a great window to show what homeopathy can do, but then we must adapt our strategy to the context of care. And I made a clear distinction between advanced, problem-oriented, and basic or community health level. And
I want to jump in for a moment.
Yeah.
I want to start with the quote, which I believe is from Yogi Berra, but I'm not sure. It's never make a prediction, especially about the future. So
let me just finish with a comment about Andre and Dr. Brands. I think Andre, what you're trying to do is impart some wisdom to the homeopaths on this call. Mostly, everyone on this call is a practicing homeopath at some level. So I think the information you're providing us is valuable, because we need to know how to take the case. We need to find that cluster of remedies. And then to Dr. Brand's point, it'll be our responsibility to share that with the world with enough instruction so that average consumers can actually use it. So I think you're both kind of speaking to the larger issue. Andre, you're trying to help us as homeopaths understand, and Martine is pointing out that once we have that data, we're going to need to find ways to get it out to folks so they can use it, because it's going to be a long time before there's a vaccine, and in fact it may be quite a long time and several phases of this epidemic before it's done?
So at this point in time, there's a lot of questions. So I'd like to open it up to questions. And I think all the things all the panelists are talking about, we'll be able to address them and go further into all the stuff we're talking about. So Peter, do you have the questions? You want to read some out, select them out?
Hello,
Hi, Jennifer.
can you hear me?
Yes.
Okay, I've dialed in on my phone. And if I could be have my video on, I think it'll be okay.
Okay. So Peter, do you want to open it up? I know some people have emailed you questions or chatted
Peter,
you.
you're muted, Peter, but I can't unmute you for some reason.
Peter, raise your right hand if you can hear me.
Yep, I can hear you. Okay,
Okay,
so
good.
here's the first question from Wayne Jonas, and that is to Dr. Sain. How do you know the differences that you presented for success during the pandemic is not due to higher aspirin rates used during that time in almost all patients? That's to Dr. Sain from Dr. Wayne Jonas. Andre, that's for you.
Yeah, there was one word that was scrambled. I couldn't hear. There was too much noise.
Okay. Dr. Jonas wants to know how, the success of homeopathy may have been related to the fact that homeopaths weren't using aspirin.
Oh, the allopath.
So he's asking, yep, the allopaths were using aspirin, homeopaths were not. Is that perhaps the reason homeopaths were more successful? He's looking for you to explain that.
Okay, I did look at this cofactor. Sure, there is a certain proportion of population, and there's a lot of study that's being done about it. We could estimate that it was a clear factor for the worst result, the poor result that were obtained by allopathy. However, many population had no access to aspirin. Is being well studied. For instance, the Eskimos, the Inuit in the north lost 90% of their adult population in some area. They had no access to any drugs, and so like same thing with islands in the Pacific. So no, this was it's a factor, but it's not a big factor in the poor result that were obtained by allopathy. However, there are really nice cases where, especially in the army, where the patient are given aspirin after aspirin, like toxic dose of aspirin, and yes, it would produce more bleeding because there were cases where they would autopsy the patient and the lungs were full of blood. So yes, it would make case much worse. What's the percentage? I would have to look in my study, but I would say it's less than 10% of the patient that were worsened from taking aspirin, mostly high dose of aspirin.
This is from Dr. Bernardo Merzaldi. He's questioning whether COVID-19 is not so much pneumonia, but lung fibrosis. Does anybody have, this could be to Dan Cook, it could be to any number of you folks. Anyone have an opinion? Is it pneumonia or lung fibrosis that we're seeing?
Well, lung fibrosis means it's an inflammation of the peripheral tissue of the lungs. It's in the lungs. We typically, pneumonitis, fibrositis of the lungs, pneumonia is more or less the same. So regardless of the pathology, the remedy should not change.
Next question is from Dr. Jeff Feynman, and this is, I think, to Dan Cook specifically. Dr. Feynman states, I heard different stats from NYU, so wonder where Don got the stats 10 times more deadly than flu. In some areas, up to 10 times, yes, but most are 1 to 3% or less. Dan, do you want to speak to that?
Me?
I got you, Dan. Go ahead.
Seasonal flu statistics are pretty clear at significantly less than 1%, and have been for years. In a very bad year like 2009, with the H1N1 epidemic, I think they got up to 2%. But this is at 4% and 5% in some areas. So it's 10 times as much on average at this point.
Thank you. And another question for Dr. Feynman is, you recommended 2-minute hand wash. The CDC and other organizations, news organizations, et cetera, are all talking about a 20-minute hand washing. Can you explain the difference in your recommendations versus theirs?
I have not heard the 20-minute hand wash, actually.
20 seconds.
20 second, my God.
As long as God save the Queen, the British said.
Yes.
Oh yeah, 20-second hand wash, that's good enough.
Yeah, sorry.
Sorry, I
didn't mean 20.
misspoke.
I misspoke too. Then there was a question from Glenna. Is there coordination among all homeopathic efforts to create a symptom database? The answer to that is yes, we've begun. AIH is taking the lead here in this part of the world, but now starting to coordinate with the Italians, the folks in India, Western Europe, etc., to create this master database that will be launched in the next 36 to 48 hours that we've been talking about. And we're going to try and have everyone from around the world feed into that system. There's going to be a panel of people that will be monitoring the data as it comes in and trying to help summarize what we're seeing with respect to a genus epidemicus on a frequent basis. It'll depend on how much data we get and the quality of that data as to whether we can, make good use of it. But we are certainly looking for cases in America from Washington, the Seattle area, obviously Los Angeles, Chicago, New York, Boston, Philadelphia. Those are all geographically different locations.
And Canada,
Yes.
not forgetting Andre and his crew.
No, but just in terms of those folks that are here from the American Institute of Homeopathy, obviously Andre is a member as well, but good point. But so we're trying to make sure, if for those that are listening from the United States, that if you're in some of those geographic areas and you're seeing confirmed cases or cases that can be suspected as, and you're going to be given the chance in the database to say, yes, it was confirmed COVID, no, it wasn't confirmed, so that we can separate out those that we know are in fact confirmed cases from those that aren't. The next question is from Lisa Amarin. Will this database be only for people who are lab confirmed with COVID? I suspect that there will be many positive cases that are not tested. In my own community here, there are a bunch of cases that doctors are pretty sure are COVID-19, but they can't get tests done. That'll continue to be an issue. So we are, as I said, the database will be open so that people can say, yes, this is verified, confirmed COVID, or no, it's not, but still fill in their data nonetheless.
May I say something?
Yeah.
Okay. The COVID test, the PCR test is only 59 to 71% sensitive according to two studies. One was 59 and one was 71. That means there's 30 to 40% of people that will show negative but are actually carrier or positive. So I think the database should be for all case of flu-like illness, because we cannot know those 30 or 40% who are they, and they should all be included.
And they will be.
I agree. Yeah. Good point.
So if there are other questions that folks would like to ask, if you can quickly, here's not a question, but a point from Joe. The data from large-scale testing in Korea suggests a 0.6% mortality rate. She can send us the reference to that. So anyway, we are trying to connect as extensively as we can with homeopathic practitioners throughout Europe, Asia, and North America. And once we get this database built out and open, we'll encourage everybody on this session to encourage their colleagues to participate if they have cases with flu-like symptoms that could in fact be COVID-19.
I have a question for everyone on the panel. I have patients asking me, well, what remedies should I have at home since going out now is being limited in lots of places, what do you recommend that I have at home? So if we talk on the phone and you recommend something, I'll have it. So I would love a list of, top 5, 7 remedies you guys recommend.
I recommend to the patients bryonia in the morning, phosphorus in the afternoon, and arsenic in the evening on the moment they start to have any complaints. On the basis of this Lancet repertorization, and I recommend anyone who suspects he might have been infected to take arsenicum every day.
Martin, what potency are you recommending?
30C.
Other panelist recommendations?
Sure.
Aconite. Tons of it.
Yeah.
It's,
Aconite?
Aconite's working great. I almost never have anyone progress past that first stage.
Yeah,
Everyone freaks out. The weather's changing, hot, cold. Aconite is 5, and it's only a single dose. You don't have to be loading people up on remedies.
So I would suggest that people should have these remedies at home. That would be good just to have these, because these would be the most commonly indicated remedy. And then we can add some more specifically for the COVID. So it would be arsenicum album, gelsimum. We could add camphora to the group here. But the more they have access to remedy, better. But if they, at the very least, if they have this, that would cover about 90% of the case, unless there's a completely different genus epidemicus. So this would be a basis to have.
But I would suggest every patient to keep contacting me daily. And if it doesn't work, I refer them to the first aid general practitioner post, which we have in the Netherlands, all over the country. And they're often located next to the emergency room. I would not take any risk.
Of course.
I understand that. I would just,
when patient feels like feverish or chills or malaise, like there would be like a flu-like illness, they have to contact you right away. And most likely, if they have those remedies, it would be dealt and it would be done overnight.
I want to give Jennifer Jacobs a chance to weigh in. You've listened to lengthy presentations and questions. Jennifer, what would you like to contribute to this discussion?
You have to unmute yourself, Jennifer. Talk to us, not just to yourself.
Okay, can you hear me?
Yes.
Yes.
Well, again, I'd like to refer to the presentation I gave. I mean, I think what Andre was talking about is the individualizing prescription. And what Martine is more concerned about is how to reach large numbers of people who don't necessarily have access to a trained homeopathic practitioner. And so in these cases, we need to think about a combination remedy of the remedies we've talked about. And we need to talk about doing this data collection so we can find a genus epidemicus. We need to have strategies on all these different levels of homeopathic treatment.
Great.
Thank you, Jennifer.
Anybody else?
There was a couple more questions. Does Andre have the reference? Does Andre have the reference for it?
Can I share something from France?
Yes.
Yes,
Bonsoir.
I can speak. Bonsoir. I would like to share with you, we have few cases in France, in Strasbourg and in Mulhouse, with very good results with beryllium metallicum. And beryllium metallicum, you don't find it if you do repertorization. You find it when you read the materia medica of beryllium in acute. Beryllium in acute, you have many symptoms, very, very, the same symptoms than in COVID. And we have good results, really, with beryllium. We give it in 9C, twice a day. And sometimes, if it doesn't work, you can give phosphorus, of course. But at the beginning, beryllium, in 1 or 2 days, the cough is better. So perhaps you can try to read the materia medica of beryllium. Perhaps you will have some idea for some patients. Thank you.
Thank you.
Thank you.
So we have about 10 minutes left, which we're not obligated to use. However, if there are more questions or comments, either from the panelists or from the listeners.
There was one question here. Trying to find it real quickly because it I think people were looking for, Andre, the data that supports your claims about the success of homeopathy with pneumonia. I just don't remember what time frame, and I'm trying to find that real quickly here. I'm not finding it quickly, but anyway.
Regardless, all the reference from the talk that I just, the little summary I gave, can be found in my answer to Stephen Novella from the University of Yale. When we had a debate, he asked me, what's the best clinical indication for the use of homeopathy? And I answer in a 450 page, and there you'll have about 500 references, many of them related to influenza, to pneumonia. Every reference is there, as well as homeoprophylaxis.
Andre, I was referring to the table you showed of the comparison of outcome with pneumonia between homeopathy and allopathy. You had a quite nice chart there. Is that something that has been published? Did you put that together from other sources?
Yes, that's what I was just saying. When I answered Novella, I documented the result obtained by homeopathy in epidemics, and everything is referenced from the literature. There's about 400 or 500 or maybe more references there. It's a 450-page paper. Actually, it's like a book, but you will find all the reference related to every report, every cohort that I found in the literature, allopathic or homeopathic, will be found in the reference will be found in the paper. And that
I'm
paper,
just saying that for that table, which was very impressive,
the table
to be
is in the
accepted.
paper. The table is in
What?
the paper. The table is in the paper.
Well, can you give us the reference for that particular table?
Yes, there is. I'll send you the paper. You'll find the table. You'll see hundreds of references.
So that table was an aggregation of many data points that Andre has uncovered. I think, Andre, if I'm not mistaken, you've been working with the Samuel Foundation to bring this paper to a publication, and that's hopefully something that's going to happen in the near future.
That's right. That's what I'm working on currently.
Okay.
One last thing. There are some people who'd like to tell about their personal experiences with COVID cases in their region. I think the place to do that, since we're almost out of time, is in that database that we'll be opening in the next day or day and a half. That'll give each of you access to leave those case reports. I think that might be an easier way to manage what are now probably 30 people that wanted to tell about their personal experiences in their particular region.
Peter, I have a practical question regarding that. Will it, and when the database is actually set up on the AIH website, will the people attending this webinar get an email saying, yes, it's now available? Or should we just ask them to go to the website in a couple of days?
My intention was, pending board approval of it, was to notify everybody by email, but also to reach out to other affiliated groups who are not part of this today, the folks in India, Italy, et cetera, to alert them to the fact that it is open and we are seeking cases. So
people can wait.
Yes, there will be an email to everybody on this webinar.
The people will be informed. Okay, great.
Yes, and we're going to be reaching out, and we'd very much like to have you all. You all have contacts around the world. Please reach out to those contacts as well, and encourage them to participate. This is obviously an important project, the most important project perhaps homeopathy has undertaken, the profession has undertaken in quite a while.
So I would like to first of all thank all the participants on the panel, because for those of you who are paying attention, they spent a lot more time than just this 2 hours. They put a lot of time and energy into preparing for this. I also want to give special note to Peter Gold. Peter tried to take this in for the countless hours you put in organizing and arranging this to happen. You don't need to unmute yourself, but silently give Peter a round of applause for the work that he's done in putting this together. I would
My
also
pleasure.
like to thank Paula Brown for making the Zoom site available for us to hold this and host this conference. This webinar will be available on the AIH website within a couple of days. Peter, will people get notice of that, or should just check the website?
I will try to make a point of letting everyone know when the recording is available. It will be free to anyone who wants to view it. And I'll also maybe simultaneously tell you the database is open. But in any event, everybody will get an email on both one or both counts.
Okay, on that note, I will not ask for a motion or a vote. I will just say, once again, thank you for being panelists. Thank you for being organizers. Thank you all for participating. And let's just go enjoy our lives with a very vital force. Enjoy the rest of your day, guys.